Dr. Corren, let's begin by discussing the pathophysiology of severe asthma. Can you explain our current understanding of the underlying mechanisms of this chronic disease?
That's a great question, Linda, and there's a lot that goes into the answer. We know over the past couple of decades that there is a lot of injury going on in the tissue in a lot of different areas. What we've really focused on more recently now is the epithelium, and how the epithelium seems to get the whole process started, how the epithelium sort of takes us into this crosstalk that takes place between the innate and the adaptive immune cells, and how this all gives rise to a number of different very important inflammatory pathways. One of the key endotypes that we've really come upon over the past several years has been the idea of what we call type 2 inflammation. And type 2 inflammation is a type of inflammation characterized by the presence of certain cell types and certain cytokines. And we can talk a little bit about the epithelium, how really it's these alarmins, that we call them, that come out of the epithelium in response to certain factors like viruses and bacteria and even allergens that dictate this entire pathophysiologic milieu, which is characterized by the interleukin 4, 5, and 13. Type 2 or T2 high asthma is the part we understand well, or think we do. Type 2 low asthma is far less characterized and far less understood. Characterization of T2 high asthma has led to the development of biologic agents that target IgE or specific cytokines or cytokine receptors involved in disease pathophysiology. There are currently 5 FDA-approved biologic agents for severe asthma. One emerging therapeutic approach to severe asthma management is targeting upstream mediators of inflammation and signaling pathways, such as thymic stromal lymphopoietin, also known as TSLP. Increased expression of this cytokine has been observed in the airway epithelial cells of patients with asthma. TSLP is one of several alarmins that is rapidly produced by activated lung epithelial cells in response to stimuli such as allergens or microbes. Alarmins serve to initiate and perpetuate multiple inflammatory signals, including the innate immune responses by activating type 2 innate lymphoid cells, which are key sources of IL-5 and IL-13, as well as adaptive immune responses propagated by activated Th2 cells. Studies have shown that TSLP may also have potent stimulatory effects on mast cells, which have been implicated in the pathogenesis of both T2 high and T2 low asthma. One biologic in late-stage clinical trials, tezepelumab, inhibits TSLP-mediated signaling by directly binding to the cytokine and preventing it from interacting with its receptor complex.
Perhaps now let's turn our attention to how we as asthma specialists use these biological agents in practice.
I think we're trying to use big data as these drugs are approved, both existing clinical trial data but also real-world use data, to determine which drug might be matched best to a particular patient. I would say predictors of response is a big one. And getting back to the idea of hypereosinophilic or severe eosinophilic asthma, in those patients, we know that this is not a monolithic event, but as eosinophil counts go from 150 or 300 and continue to rise, certain drugs will do better than others. I think where choice becomes much more difficult is in patients who have low eosinophil counts. And perhaps here, this is where exhaled nitric oxide can help us. In a patient with a low eosinophil count and who's non-allergic, but does have an elevation of their exhaled nitric oxide, there is a biologic that would work for these patients, and potentially would be dupilumab. So predictors of response, not only limited to biomarkers like blood eosinophils or exhaled nitric oxide, but looking at a number of other things: age of onset, severity of physiologic impairment of pulmonary function, other quality of life disruptors seen with the disease.
How do you think that this armamentarium of treatments we have for severe asthma is going to change in the next few years?
Yes, I think that's an interesting question as we try to ponder what the last couple of years of clinical trials have taught us and what we can look forward to in the next 5 to 10 years. I think this new decade will be the era of the epithelium.